Our next subject will be about epidural versus CSE versus DPE for labor analgesia. It will be presented by Dr. Cynthia Wong, who is a professor, chair, and department executive officer of anesthesia, division of obstetrical anesthesia in the University of Iowa.
Good afternoon. My name is Cynthia Wong, and I am tasked with speaking to you today about epidural versus CSE versus DPE for labor analgesia. I don't have any disclosures to make relative to this talk, although we will talk a little bit about off-label use of drugs. Actually, most drugs that we use for obstetric anesthesia care are off-label. So the objectives of the talk are to differentiate the benefits and risks of initiating neuraxial labor analgesia with an epidural, CSE, or DPE technique. Let's start by some definitions. So I think we're all aware of what an epidural technique is. We put an epidural needle in the epidural space and quite commonly thread a catheter through the needle and deliver anesthetic medications, usually a mixture of local anesthetic and opioid, into the epidural space. Combined spinal epidural is when we initiate analgesia with a spinal dose of usually local anesthetic combined with opioid. So we advance the epidural needle into the epidural space and usually using a needle through needle technique, advance a longer spinal needle through the epidural needle until it punctures the dura, and we administer a spinal dose, withdraw the spinal needle, thread the epidural catheter, and then maintain labor analgesia with the epidural catheter, hence combined spinal epidural. And the newest technique, been around for approximately a decade, is called dural puncture epidural, where the technique is the same as a CSE. So the epidural needle is placed in the epidural space, the spinal needle is advanced through the epidural needle and punctures the dura, but no drug is administered into the spinal space. The spinal needle is withdrawn and the epidural catheter is threaded, and again, analgesia is maintained with the epidural catheter. So here the idea is to put a hole in the dura. That's the only thing that's done differently from an epidural, and no, again, spinal dose is injected. So let's talk about a couple of cases and why each of these techniques might be appropriate, more appropriate, less appropriate for each one of these cases. Case one is a nulliparous patient, first baby, term, 5 centimeters cervical dilation. She's requesting neuraxial labor analgesia. How would you initiate neuraxial labor analgesia? Would you use an epidural technique, a CSE technique, or a DPE technique? Let's start by articulating the advantages and disadvantages of each one of these techniques. So with an epidural, no dural puncture is required. The onset of analgesia is slower. I will show you that data in a minute. One needs to use a larger drug dose for an epidural dose compared with a spinal dose. Because one needs to use a larger drug dose, there is an increased risk of local anesthetic systemic toxicity, or LAST, if that dose is accidentally injected into a blood vessel instead of the epidural space. And again, because one uses a higher dose, there's more absorbed into the bloodstream, and there's increased fetal exposure to our anesthetic drugs. What about the advantages and disadvantages of CSE analgesia? Well, an advantage is that we use a low drug dose to initiate analgesia. So there's a much lower decreased risk of LAST. Even if we accidentally injected the spinal dose into a blood vessel, nothing bad would happen. Onset of analgesia is more rapid than an epidural technique. Of note, onset of sacral analgesia is more rapid, and we'll talk about why this is important in a minute. One can get complete analgesia with spinal opioid in early labor, and again, we'll discuss this in a minute. And there's a decreased incidence of failed analgesia when the epidural catheter is placed as part of a CSE technique compared with an epidural technique. The disadvantages is that a dural puncture is required, requires a spinal needle. The spinal needle is more expensive. There's an increased risk of pruritus when the opioid is administered into the spinal space compared to the epidural space. And there's an increased risk of fetal bradycardia, which we will also talk about in a minute. What about dural puncture epidural analgesia? Well, the advantages and disadvantages haven't been as well delineated, and the studies are a little bit heterogeneous. They're inconsistent with each other. So some of the studies show that there is a intermediate onset of analgesia between a CSE and an epidural. In other words, it's faster than an epidural, but slower than a CSE. Some studies, but not all studies, again, show that there's better sacral analgesia with the DPE compared to the epidural, and we'll talk about why this is important in a minute. There is possibly a lower risk of fetal bradycardia than CSE. Again, has not been well studied. And it seems like there's probably a decreased failure rate compared to an epidural. Has not been compared in this regard to a CSE, and I'll show you the limited data on this too. That's why there's question marks after all of these advantages. Disadvantages, similar to a CSE, a dural puncture is required, requiring expensive spinal needle. A larger drug dose than a CSE, so the drug dose is similar to an epidural. That's associated with an increased risk of last, and again, an increase in fetal exposure to our drugs. So let's first talk about latency or onset of analgesia. This was a randomized controlled trial that was done a number of years ago that compared two epidural techniques. So the blue line is traditional epidural. The red line is an epidural with opioid. So this was back in the days before we routinely used opioid in the epidural space. And the green line is a CSE technique. And you can see that after 10 minutes, 100% of patients in the CSE group had a pain score that was 0. And it took over 25 minutes for the epidural groups to get a pain score that was less than 1. So significantly faster onset of analgesia with a CSE technique compared with an epidural technique. This is the one randomized controlled trial that I'm aware of that compares all three techniques. So epidural compared to DPE compared to CSE. So again, a Kaplan-Meier survival curve that looks at onset of analgesia, all right? The red line, the red dashed line is CSE, so it is significantly faster than the other two techniques. Again, you can see that by 10 minutes, about 80% of the CSE group had a pain score that was 1 or less, whereas it was much higher for the DPE and epidural groups. And similarly, at 30 minutes, almost 40%, 40 to 50% of the epidural and DPE groups still did not have a pain score that was less than or equal to 1. So again, significantly faster onset of pain and arguably better pain control with the CSE. You might ask me whether it makes a difference whether a 25 gauge hole or a 27 gauge hole is made in the dura. After all, for a DPE technique, if the idea is to put a hole in the dura so that more drug crosses the dura in a faster rate, maybe a bigger hole will make a difference. This is the only randomized controlled trial that I know of comparing two different gauge needles. And if you look at time to onset of pain relief, again, pain scores less than or equal to 1. There was a non-clinically significant shorter onset of analgesia in patients who are randomized with the 25 gauge versus the 27 gauge needle. So you can see the difference here is about a minute and a half, or a little bit less than a minute and a half, which most of us would think is not clinically significant. The time to a bilateral sacral block, that's the next line down, was not different between the two groups. Why are we talking about a sacral block? Why is that important? Well, let's review labor pain in the different stages of labor. So on the y-axis here, we have cervical dilation, and on the x-axis, we have time. And you can see that the stages of labor are divided into the first stage, the second stage, and the third stage, right? The first stage is from the start of labor until complete cervical dilation at 10 centimeters. The second stage is 10 centimeters until delivery of the baby. And the first stage is divided into the latent phase and the active phase. So during the latent phase, most of the work of labor is what's called ripening the cervix. And so the pain is coming primarily from the cervical region of the uterus. And if we look at how the cervix and the uterus are innervated, we can see and we know that the nerve roots follow the sympathetics back to the spinal cord. and enter the spinal cord in the low thoracic, high lumbar area. So historically, we say that these nerve impulses come back to the spinal cord, these sensory pain impulses at the T10 through L1 level. Now, as labor progresses and the cervix starts to dilate even more, so this is the active phase of labor, the baby starts to descend in the birth canal, and the birth canal is innervated differently, right? It has sacral innervation, S2 to 4. So we start recruiting these sacral nerve roots. And then finally, in the second stage of labor, during the pushing phase, so the baby is really descending through the birth canal and the perineum to be delivered, then we've got a significant amount of sensory stimulus that is from the sacral nerve roots. Another picture of the same thing, right? So early in labor, low thoracic, lumbar processing of pain. Later in labor, both. So the lumbar and the sacral regions are involved. And we put our epidural catheter usually in the mid-lumbar epidural space, right? L2-3, L3-4, maybe even L4-5, which means that our anesthetic solution, again, usually local anesthetic combined with opioid, has to go up in the epidural space to the thoracic region, and it has to go down in the epidural space to the sacral region. And again, early in labor, it's got to go up, and late in labor, it's got to go, later labor, it's got to go in both directions. When we inject solution into the lumbar epidural space, it preferentially wants to go up. It's just the way the anatomy of the space is. So this works quite well if we want to do an epidural early in labor, because most of the pain is being processed in the low thoracic spinal cord. So going up is good. But if we initiate labor analgesia later in labor, where the local anesthetic solution needs to go in both directions, sometimes the patient doesn't get complete pain relief because the sacral nerve roots are not being adequately covered. The local anesthetic solution doesn't go down as well as it goes up. If you look at a CSE versus an epidural technique, this is a randomized controlled study again, and you look at the outcome of bilateral S2 blockade at 10 minutes. This first column, CSE, you can see that the sacral block occurs in almost 100% of patients at 10 minutes, and for sure at 20 minutes, 100% of patients have sacral coverage. Where if you look at the patients who are randomized to an epidural technique, at 10 minutes, only about a third of patients had their sacral dermatomes blocked. And at 20 minutes, only about 2/3, right? So the sacral dermatomes are much harder to block if one uses an epidural technique. If labor is going to last a long time and you redose the epidural, or you have a continuous infusion going over a number of hours, then eventually most patients will develop a sacral block, but it takes a while. And again, if labor is going quickly and the patient is expected to deliver in the first couple of hours, this sacral block may not develop. Here is a systematic review meta-analysis, so a forest plot of studies that have compared DPE versus epidural for a sacral block. Again, one of the purported advantages of putting a hole in the dura is that there is better spread of local anesthetic from the epidural to the spinal space, and therefore one would get a sacral block faster. That was the hypothesis. You can see again that the results are heterogeneous. I referred to this at the beginning of the talk. They're inconsistent. There are a couple of studies that showed better sacral coverage with a DPE and other studies that showed no difference. And if you look at the meta-analysis, you can see that the risk ratio covers 1, includes 1. So these authors concluded that there was no difference in the onset of sacral blockade between a DPE technique and an epidural technique. Another difference that these authors looked at in this meta-analysis was the number of PCEA boluses, all right, that were required throughout labor. And you can see that actually patients who were randomized to the DPE technique required a few fewer boluses. So the difference was -2, 2.3 boluses. So it seems maybe that the DPE offers slightly better analgesia than the epidural technique, but it's not marked. All right, what about pain scores with the CSE versus epidural technique? Well, again, this is a randomized controlled trial done in a large maternity hospital in the United States. And the authors asked the patients for their average pain score during the first stage of labor, second stage of labor, and at delivery. So at the end of the first stage of labor, they said to the patients, what was your average pain score on a 0 to 10 scale? And you can see that with the patients that were randomized to the CSE technique had slightly lower pain scores, 1.4, compared to the epidural technique, 1.9. You may say that this is not clinically significant, and you might be right, but it was a pretty rigorous study, and I think this finding is correct. Not much difference in the second stage and at the time of delivery. The CSE technique required fewer top-up doses by the anesthesia provider. So again, this suggestion that overall analgesia was better because there was less breakthrough pain, 16.4% compared to 25%. All right, what else might be different between these analgesic modalities? Well, one thing I wanted to talk about was fetal bradycardia. This is not something that we'd like to see, and we certainly don't like to see that our analgesia technique is associated with fetal bradycardia. It is, though, sometimes, all right? And what we think is happening here is that our analgesia techniques are contributing to uterine tachysystole. In other words, the uterus is contracting too much, and the uterus does not perfuse during systole, just like the heart. And so when there's decreased uterine perfusion, decreased oxygen flow to the baby. What do we think is going on here? Well, during labor, before we initiate analgesia, catecholamine levels increase markedly in the mother. And after we give analgesia, one can imagine, and this is true, that catecholamine levels, both circulating epinephrine and plasma norepinephrine, decrease. All right, why is this important? Well, what we think is happening is that when we have a decrease in circulating epinephrine, the beta-2 effects of the epinephrine go away. What are the beta-2 effects on the uterus? It causes the uterus to relax. And you can imagine we've got this sort of competition going here where we have circulating oxytocin that is causing the uterus to contract, and circulating epinephrine, which is causing the uterus to relax through its beta-2 mimetic actions. This is going along, and the two are in balance, and then we come along and we give excellent pain relief, and the epinephrine levels all of a sudden go down, and we've got overriding oxytocin levels, and the uterus contracts more than we want it to, and has uterine tachysystole. In other words, the uterus is not relaxing enough to provide blood flow to the uterus and therefore oxygen to the baby. Causes fetal hypoxemia and eventually fetal bradycardia. There was a randomized controlled trial in Brazil a number of years ago comparing the epidural technique to the CSE technique with the outcomes of fetal bradycardia and fetal tachysystole. What the authors found was that the incidence of both of these, fetal heart rate decrease and uterine tachysystole, within the first 15 minutes after the initiation of analgesia, occurred more commonly with the CSE technique than the epidural technique. Now, a limitation of this study is they only watched for 15 minutes. And we showed earlier that it takes a good half an hour to get optimal analgesia with an epidural technique. And so, again, I think a limitation is they did not wait for at least 30 minutes with the epidural technique. Fetal bradycardia also occurs with the epidural technique. It just occurs later because the maximum onset of analgesia is later. The other thing that these authors pointed out was that the estimated probability of fetal bradycardia, which is on the y-axis of the graph, increases with the degree of pain relief. So, for example, if a patient started with a pain score of 10 before the initiation of analgesia, and afterwards they had a pain score of 0, so changed was -10, then they had a significantly higher risk of fetal bradycardia compared to a patient who basically had no change in their pain score. In fact, this pain score went up to 2, right? So I think this is important and may explain the reason why we see more fetal bradycardia with the CSE versus the epidural technique, because the pain relief is more rapid and more profound. All right, so back to our first case, nulliparous patient, 5 centimeters cervical dilator requesting neuraxial labor analgesia. There are pros and cons of all three of these techniques, but I don't see that one has a market advantage over any of the other ones. And I think you could pick any one of these and the patient would get adequate and very satisfactory analgesia. But let's move on to a couple of other cases. So this is a multiparous patient, G3P2 term. She's at 7 centimeters cervical dilation when she requests neuraxial labor analgesia. So she's in the active phase, right? Remember the labor curve graph that we showed earlier in the talk, which means that her sacral dermatomes are going to need to be blocked within a short period of time. Labor is faster in multiparous patients, remember that. And so this woman is already at 7 centimeters. So how will you initiate neuraxial labor analgesia? What I would argue that this is an indication for CSE analgesia, again, because of its short latency, number one, and number two, because it covers cervical dermatomes quickly. So again, the picture that we showed before, you've got to get your anesthetic solution to go both up and down, and that is difficult to do with a straight epidural and much easier to do if you inject the anesthetic into the spinal space. All right, what about this patient? This is a nulliparous patient, also a term, 3 centimeters cervical dilation with a history of hypertrophic cardiomyopathy requesting neuraxial labor analgesia. Well, this is a patient where you want to be particularly careful not to decrease both preload and afterload too much, right? This will worsen the patient's cardiovascular status and might lead to cardiovascular collapse. So one very useful technique is to induce analgesia without ever using a local anesthetic, and therefore you will not get sympathetic blockade and this decrease in preload and afterload. Early in labor, you can give spinal opioid, for example, a dose of spinal fentanyl or sufentanil, and you will get complete analgesia. This doesn't work later in labor. So later in labor, again, when you need to recruit the sacral dermatomes, you need both local anesthetic and opioid. But early in labor, you can give only spinal opioid. You get complete analgesia, and you never have to bolus inject the local anesthetic. You could then start an infusion through your epidural catheter and slowly bring on the local anesthetic and the sympathetic blockade, and not have as large a risk of cardiovascular collapse in this particular patient. You could also argue that an epidural technique would be appropriate, but again, you have to bolus the epidural space with local anesthetic, and you might get a sympathetic block that the patient doesn't tolerate very well. By the way, you cannot get complete analgesia with epidural opioid. It takes a very large dose, and since the epidural space is quite vascular, you'll get significant absorption of the opioid into the bloodstream and the side effects of systemic opioid analgesia. All right, here's another patient, G1P0 term. She has preeclampsia. She's early in labor, 3 centimeters cervical dilation, but the obstetricians are concerned about her fetal heart rate tracing. It's non-reassuring. They're very worried that she's going to have a C-section before she can deliver vaginally. How will you initiate labor analgesia? Well, here I'm going to argue for either a CSE and a DPE. And the reason is the evidence shows that there is a decreased risk of catheter failure rate if the epidural catheter is placed as part of one of these two techniques. So here's a study, a large retrospective study showing that the overall failure rate of the epidural is 14% compared to 10% for the CSE. Inadequate epidural analgesia and catheter replacement, again, higher with the epidural technique compared to the CSE technique. What's going on here? Well, probably when we put the epidural needle into the epidural space and put a spinal needle through it and see CSF, we know that the tip of the epidural needle is in all likelihood really in the epidural space, and it's probably in the midline of the epidural space. If you put the epidural needle off to the side and you advance the spinal needle, you will not puncture the dura, and you may get a one-sided block. So the seeing CSF come back through the spinal needle is a very good indication that your epidural needle and therefore epidural catheter will be in the right place and will not fail. So here's just another study. This one is from Singapore, showing the same thing. There is a different distribution of success and failure of the epidural catheter at cesarean delivery. So this is what we were worried about in this particular patient. In patients who get a CSE, much higher incidence of success compared to women who got a straight epidural. So epidural catheters fail at a higher rate if they are placed with just an epidural technique and not a CSE technique. This was a study that was done a couple of years ago where they asked women who were undergoing elective cesarean delivery. So we would normally do a spinal anesthetic for this, right? But they put epidural catheters in these women to kind of pretend that they were in labor. So they randomized women to a DPE versus epidural technique, and they started them on a labor infusion, even though they weren't in labor. And an hour or two later, they dosed the epidural catheter as if they were going to have a C-section. They were going to have a C-section, right? But they were just pretending they were in labor, put in the labor catheter, and then pretended that there would be an intrapartum cesarean delivery, and so injected local anesthetic through the epidural catheter. And if you look here at the rate of onset of the surgical block, the orange line is the DPE technique and the blue line is the standard epidural. And you can see that the time to onset of a T6 level, which is the level that you need to do a C-section, was significantly faster with the DPE technique compared to the epidural technique. So again, if we're going to have an emergency C-section during labor, it appears that if there's a hole in the dura, either from the CSE technique or for the DPE technique, the onset of anesthesia, surgical anesthesia, will be faster with those two techniques. So just want to emphasize as we conclude this talk that neuraxial labor analgesic is not a generic procedure. We can do different things for different patients depending upon their needs. One size does not fit all, and I think you should have all of these techniques, both the epidural, traditional epidural technique, the DPE technique, and the CSE technique in your armamentarium and use them appropriately for different patients to address their different needs. Thanks very much for listening, and I'm happy to answer questions later.